Thank you. We wanted to thank you for inviting Dr. Welsh, Jenny, and myself to be here today. We are excited to share with you some of the updates on the new Family Health Center, as well as some of the programs we're working on both in and around the Lakewood Family Health Center. We're really thrilled to be here. We think this is a great time for Lakewood. There are a number of initiatives coming up that are helping us to achieve a critical mass for positive change in the city of Lakewood. I can tell you with sincerity that the three of us here and the teams that we represent have fallen in love with the city. We are invested in the success of the community. We are seeing many of Lakewood's patients every day in our clinical practices, and our understanding of the needs of this community is growing. But we also appreciate there are views of members of the community who have lived here, some of them their whole lives, that are important for us to hear and to understand. So as we talk a little bit about what we are trying to do here in Lakewood, I wanted to share with you a vision statement. This is the vision that we have for the Cleveland Clinic in Lakewood. We hope to be a reliable partner in an integrated and coordinated approach to health and wellness, which is inclusive of health systems and community organizations, and that removes barriers to healthy living for all of Lakewood's people. The second statement here is our wish for the people of Lakewood. Everything we hope for this community is distilled into that statement. Within 5 years, it's our hope that a Lakewood community member will be able to say that through the Lakewood Family Health Center's focus on population medicine and efforts of others in the community, that my family and those I care about are healthier and have a better quality of life. This really is it. This is everything Dr. Welsh, Jenny, and I, along with our teams, hope to accomplish. Nothing more and nothing less. We believe that a rising tide lifts all ships and that a healthier Lakewood benefits everyone who lives and works in the city. So some objectives of the talk today is to update this task force on the progress of the new Lakewood Family Health Center, the physical structure, as well as give a broad overview of the current initiatives our teams are working on in the city. We'd also like to introduce current and potential future collaborations with community partners to improve health and wellness and employing techniques of population health. So to begin with, I'd like to say that as caregivers, we approach the topic of health and wellness from a little bit of a different perspective than our public health colleagues or those directly involved in health policy. We're out there in the field with patients every day. In fact, the majority of our time, Dr. Welsh and myself, is spent seeing patients. Our training is in the care of the sick and the way to utilize preventive care to make illness less likely. We talk to patients one-on-one. So with this focus on caring for the sick and one-on-one care, population health is a bit of a stretch from our training and our background. But it does give us, I believe, an appreciation for concrete, practical solutions to solve the problems we're faced with. So the presentations you see today may have a slightly different flavor than those who are involved in policy and public health, but we believe that all of these voices are necessary in this discussion. So to that end, we wanted to begin with just a discussion of, introduction of population health. When you talk about population health, it's a buzzword used frequently currently, but there really is not a single understanding of what population health means. If you ask 5 different health professionals, you'll likely get 5 different answers about what population health is. We feel it's important that we define the term and move toward a common understanding of health outcomes and social determinants of health and wellness. This particular quote, to me, characterizes and defines the current state of population health as it means to us at the clinic. Many progressive healthcare organizations are doing cutting-edge population health management, but are also working with our partners on total population health across geographical or geopolitical populations. In such cases, it would be appropriate to label these efforts as population medicine, expanding into total population health. This is from David Kindig in the Health Affairs blog. So as we move on to the community needs assessment. And I'm not going to obviously spend a lot of time on this because this group had a thorough and eloquent review of the community needs assessment by Kristen Creation and Martha Halko at the previous meetings. But it's important that I say that everything we design at the clinic is based on the needs that are identified in the community needs assessment. So we see from this particular table, which shows us this is from the CDC Burfus study, which shows us the conditions that are more highly represented in the city. We see that Lakewood is generally doing better in regions of categories of back pain, high blood pressure, and high cholesterol. But on the flip side, compared to other areas in Northeast Ohio, Lakewood has high rates of diabetes, asthma, and smoking. The next are the PQI indicators, which you reviewed. And these, in layman's terms, they tell us which patients could have avoided hospitalization if they had good access to high quality ambulatory care. And we can see that the biggest areas where we can have the largest impact is by focusing our efforts on the prevention and treatment of diabetes, heart disease, lung disease, urological conditions. But also from stakeholder interviews and other data, we know that care for seniors, mental health, and substance abuse treatment, education and development of physicians to fill primary care shortage areas, and programs for working families are key areas where interventions can have a significant impact. So by now many of you are familiar with the artist rendering. We're pleased to share with you that, well, and you've read it in the papers, I'm sure, a couple of weeks ago, we put the final beam in place for the steel structure. We had a number of caregivers who participated in the ceremony, as well as the construction workers. We at Lakewood are very excited about this next step. As you'll recall, I believe, the first floor will house a 24/7 emergency service, 20-bed ED. Dr. Welsh will be the lead for that, and she'll tell you a bit more about our emergency department during her presentation. The second floor houses the Cleveland Clinic Center for Family Medicine, which is a top-notch educational program with a mission to provide community health in a patient-centered medical home. Our third floor is comprised of internal medicine, medicine subspecialties, surgical subspecialties, mental health, care coordinators, nursing, ambulatory lab, and administration. So just to give you time limits us going through every floor in detail, but this is our third floor. This is the one I know best because that's where I will be working. If you look at the perimeter of the building, these are our patient exam rooms. The waiting area for patients will be all along Bell Avenue there on the right-hand side of the screen. In the middle, those banks of seats, that is the co-location of the physician with the medical assistant. Evidence has shown that medical assistants next to their physician staff leads to greater communication and collaboration. So to the bottom there will be our internal medicine. Behavioral health will be up towards the left. Medicine subspecialties in the left corner. To the right is all diabetes. You'll see to the far right we have a shared medical appointment room, and we feel that that is a key element to providing population health, as well as group education rooms, which we will be using and certainly will be available to community organizations should they need a space such as that. This is a little bit of information about not a population health tool, but this is the patient-centered exam room. With the patient-centered exam room, groups of architects and designers, as well as the users of the room, including physicians, nursing, and patients, of course, have come through and looked at a number of different mock-ups of what the exam room will look like. If you can see that the physician is represented in the diagram by the box. That doesn't exactly match the picture we have there, but the box is mobile. We'll be looking at the patient in the green oval chair, which will fold downward and become a bed. The guests in the room will be in the two gray seats to the side. And on the right there is a potential, and some of the rooms will have this to begin with, for a television or a monitor, so that we can potentially beam in a specialist who, if a question comes up that's easily answered, that we can access a specialist who's on call right in the exam room, will be able to do that. Also, this will be something directly applicable to population health if we use that exam room for specialists to reach out to the community and do consults with folks in their homes. We don't know yet exactly all of the possibilities of this, but we're excited that we'll be able to start exploring the application of technology in population health. All right, so this is the Center for Family Medicine, and we're thrilled that they're going to be coming. This is a group that has community involvement in their bloodstream. Population health has been part of their training program since the 70s, I believe. And they've been doing this before the rest of us caught on to the idea. These family medicine residents are completing a 3-year specialty training in family medicine. For those of you who don't know the training makeup of family medicine physicians, it's broad-based, and it includes pediatrics, internal medicine, obstetrics, emergency medicine, dermatology, cardiology, surgery, behavioral health, sports medicine, geriatrics, gynecology, orthopedics, allergy, ENT, ophthalmology, urology, community health, osteopathic medicine, mind-body medicine, and all that in 3 years. I'm glad I chose internal medicine. That's a little easier to bite into that. All of the resident physicians are supervised by an experienced family physician faculty. The current number of residents is planned for 18. This is likely to grow to 24 in the coming years. Already, the residency faculty has expressed interest in developing partnerships with community organizations. Specifically, they had mentioned the Westerly Apartments and Barton Center, as well as the school-based health program, to work with the populations that are in those locations. A little bit about the faculty. You can see some of their background and training. On the bottom, well, there's a couple of things I'd like to highlight here. We do have a faculty member with an interest in geriatrics care, who's done research and is well known in the field, as well as Robert Kelly, who has a focus in integrative and holistic medicine. I know that's been an area that the city has sought to include in healthcare in Lakewood, so we're excited that he'll be joining us. In addition, the bottom right is to remind me that the Ohio Heritage College of Medicine will be having 12 medical students join the Center for Family Medicine. So in addition to the 24 residents, there'll be 12 medical students per year. They are required to do electives in community health from the very beginning of their training, including community research. We're excited that they'll be joining the program. Just to give you an idea of the track record of the family medicine residency, of 215 graduates, there are some practicing in 27 states. However, 135, so a good chunk of them practice in Ohio. And of those 135, 105 are in the Northeast Ohio area. So you can see the distribution there. We are excited that once they get a taste of Lakewood, that will want to settle, become physicians actively practicing in the area, as well as surrounding communities to help improve the number of physicians in and around Lakewood. So a few words about the school-based health program. This is a program in Northeast Ohio, sponsored by the Cleveland Clinic Children's program. It currently serves 23 schools in 6 school districts. The first district was Maple Heights in 2014, followed by Euclid, Lakewood, Cleveland Heights, University Heights, Warrensville Heights, East Cleveland, and Cloverleaf. We are excited that the Cleveland Clinic Children's Program and Lakewood Family Health Center and the Lakewood School District are joining forces to launch the Cleveland Clinic's first in-school health clinic in Northeast Ohio. Now, this will not replace the current nurse, the current health services for the school will still be intact. This is optional. Patients, meaning students and family, as well as the staff of the school district, will have the opportunity to be seen for urgent care, routine matters. For instance, some of the services that are provided by the school-based health clinic are screening exams, acute and chronic illness care, immunizations, health screenings, BMIs, hearing tests, vision, depression screening, scoliosis screening, routine lab tests, management of chronic diseases, behavioral health screening and behavioral health services, adolescent sexual health screenings, and management, after-hours nurse triage and advice. So a little bit about the actual structure. The clinic will be located within the Lakewood High School. It provides 2 exam rooms, a conference room, and office space for telehealth, behavioral health consults, and shared medical appointment space. An advanced practice professional will serve students and school faculty and the staff. There will be dedicated clinical time to the teen health mission, which has been an important program in this city. We're also excited to bring the Navigator program to Lakewood Family Health Center. This is currently employed at the Cleveland Clinic in Tausig and Stephanie Chubbs Jones Family Health Center. This Navigator program involves full-time community health workers to create connections between vulnerable populations in our healthcare system. So we're planning on 2 navigators to begin with the opening of the new Family Health Center. Their role will be tailored to our city's needs, but the idea, this is above here, is the idea of how this is looked at Stephanie Tubbs Jones. They will be there to help with community outreach, pairing patients or future patients with financial assistance, linkage to services, and clinical care coordination for the sickest of those that they encounter. So this is the next slide is quite busy, but the goal of the Navigator is to identify barriers and then navigate those patients over those barriers. They're the first point of contact for patients. They will help us maintain and develop relationships with community groups, and they will be actively providing health and wellness programming to patients and in the community. I was asked to say a few words about the program for LGBT health. These we've identified as social, well, not we, but the HRC has identified as social determinants of LGBT health. We know that 56% of lesbian, gay, and bisexual patients have experienced some form of discrimination in healthcare. 70% of transgender patients have. They face discrimination as well in insurance, employment, housing. We know that there is a shortage of healthcare providers who are knowledgeable and culturally competent in providing care to the LGBT population. So I think it was Martha who brought this slide in earlier. Yeah, I was listening to the recordings on the website. You know, other people listen to Rihanna or something on the Stairmaster. I'm listening to the Community Health Needs Assessment. So we have equality, which is fairness. Everyone gets the same, but the outcome is different. Some people can see the game. Some people can see the back of the fence. Equity is adjusting the tools that are given to each participant to achieve an equal outcome. In this case, it's 2 boxes for the smaller child and 1 for the medium-sized child. So we hope that with our program for LGBT care, we're able to give our LGBT population a bit of a helping hand to make them feel welcome, to remove barriers to access. A little bit about why we did it here, Lakewood. If you look at from the 2010 census, the top 5 cities for same-sex couples, Lakewood is at the top in a per capita analysis. Also, HIV incidence. This is from 2012, 2013 incidence data. You can see the 44107 in the immediately adjacent region of Cleveland are the highest incidence areas for HIV. So certainly there is a need here, a need that we hope to meet with our program. These are a number of our providers. medical assistants, nurse practitioner, RN care coordinator, our transgender patient clinical coordinator. They're all working at the Lakewood Family Health Center currently. And then finally, for my portion here, I wanted to just say a word about mental health. We understand that there's a significant need for mental health. This was identified, mental health services. This was identified by stakeholder interviews during the community needs assessment. It was reinforced by a recent meeting that we held with the Department of Human Services, or the Human Services Subcommittee of City Council. We've heard the communications loud and clear. And I can tell you that the mental health care in this family health center will be more than any family health center I've ever worked at. We'll have adult psychiatry, both MDs and advanced practice professionals. Child and adolescent psychiatry will be present, psychotherapy. The mental health teams will be co-located with the primary care teams, which allows a very convenient, effective way to engage the patients in their treatment. You can introduce the person that you're seeing in your office with their mental health professional in real time. We're also planning to locate a strong community mental health center partner within the facility. This model has been successful at Stephanie Tubbs Jones, where the Centers for Families and Children have been providing patients with comprehensive mental health services. Those services include medication management, individual and group therapy, and case management. And that is the end of my time. I would like to pass this to Dr. Welsh.
Thank you very much. That was a lot of information. You're a tough act to follow. Go ahead and open. Let's see. Go ahead, ED update. All right. Slideshow. I think I've got it here. I might need some technical assistance.
Yep.
My apologies.
No, you're fine. I was trying to see if I could do it from.
All right, so a little bit of a heavier topic, but one that's very important to us as healthcare providers is the opioid epidemic in the city of Lakewood. So as a physician and as somebody who's very metrics driven, I feel that looking at the numbers really illustrates the burden of suffering and the importance of the problem. And so what you can see from this slide, I think I'll go ahead and use the pointer. That's where we were last year, 666 overdoses, and that is where we are projected to be this year, is well over 700 overdoses. When we look at what's causing most or driving most of the issues, it's right here. It's fentanyl. Fentanyl is an opiate analgesic that's between 30 and 50 times more potent than heroin. And so this is being added to the packages, to the heroin that's being sold on the street, and is poisoning people. And unfortunately, sometimes addicts actually look to find the fentanyl because it's felt to be more effective in getting people high. Look at the next one. Again, you can see here there's a very substantial increase in the total number of opioid-related deaths in Cuyahoga County, and much of that is being driven by either fentanyl alone or by fentanyl in combination with heroin. And heroin alone is becoming much less of a significant player in what we're seeing clinically. So just to put it in perspective, I think it's important to kind of think again in terms of numbers. And when we look at the entire time of the Vietnam War, there were about 58,000 casualties in U.S. Military members. When we look at what happened last year, there's between 59,000 and 65,000 deaths that were estimated to have occurred as a consequence of the opioid epidemic in the United States. So this is a massive, massive problem that's causing serious harm to people that we know and love. And when we look at who's dying, these are people at the prime of their lives. These are individuals between 18 and 50 years of age. And it's now the #1 cause of death in these individuals. When we look at our county in particular, there were 39 formal deaths that were certified. And again, it takes weeks and weeks to get the toxicology results back. So these are just the ones that we know of. There will probably be more eventually reported. 3 of them were individuals who died in the city of Lakewood. And the thing that's most important to me is that 2 of these people were my patients. I was the doctor who had to declare them dead. So this is very important to us, both personally and professionally. So our response to this is not just to kind of, roll up the tent and, throw up our hands and say nothing can be done. We're working to try to actually address the issue. And so a multidisciplinary group, many, many people. In fact, I was in a meeting yesterday, and there were probably 50 people at the table. People from government, people from the healthcare fields, individuals from county health and management, the public health folks, the recovery community, police, fire, EMS. Everybody came to the table to contribute to the development of this program. And really the goal is to engage patients directly to try to get them to stop using opiates. And so our goal is to reduce opiate misuse and the number of fatalities that occur in the city, and to provide rapid access to treatment right away, immediately, in the teachable moment. And so what we're going to be doing is the first of its kind in Northeast Ohio. It is based upon existing successful models, but nothing has been done exactly like this than we've been able to find. It utilizes peer supporters to come right to the patient's bedside following an overdose to engage them in treatment. Somebody who's been there, who has had this problem themselves, and can speak to the patient directly and help them navigate the treatment resources available. So the points of access, and I'll just really touch upon them briefly, really focus on just the Lakewood Emergency Department. That's my home. There will be the Lakewood Emergency Department, the Lakewood Fire Stations, and private visits that will occur in the patient's home. So who are the peer supporters? These are a dynamic group of people that are really incredible. They're individuals who are in long-term recovery. They have undergone special training and certification by the state of Ohio. They provide services without charge. The care that they're giving to our folks is going to be underwritten by the Bureau of Justice Assistance grant to the Adams Board, and it will be managed by the Woodrow Project, which is a sober living residence right here in the city of Lakewood. So what's going to happen, our workflow essentially is that we will resuscitate a patient from their heroin overdose, and this usually happens very quickly. Once you're given Narcan, you go from blue and nearly dead to awake and angry, and it happens in a matter of seconds. It's probably one of the most dramatic things you'd ever see when it occurs. So once the patient is medically stable, which for most 20 minutes, half an hour, we have an opportunity to have a conversation with them, to talk to them about what happened, and we offer the option. Would you like to talk to a peer supporter? I can give them a call. They can come right here to your bedside, and they can meet with you and talk to you about how can we prevent this from happening again to you? What can we do to get you into treatment, to get you to quit using drugs? The peer supporter will discuss their own personal experiences. They're going to talk to the patient about options for detox and recovery. And if the patient agrees and is appropriate, they will have an immediate substance abuse assessment. They will be taken down to the Adams Board to a crisis bed. The substance abuse assessment will be undertaken at that time. And then if they meet criteria and it's appropriate, they'll be admitted right into a detox bed, right from our emergency department. They will also provide support to the patient's families as well, because when abuse of drugs occurs, it doesn't occur only to the patient. Their behavior affects everybody around them, their mothers, their fathers, their children, their significant others. It doesn't happen in a vacuum. So our current state, when somebody overdoses on opiates, when we resuscitate them and they become medically clear, we discharge them. Unfortunately, there's not a lot of options right now for getting people immediately admitted to an inpatient detox bed. So we give them a list of resources, and we tell them, I'm sorry, but you're on your own. You can talk to your primary care doctor. Here's a list of outpatient resources. There's a lot of great places. Unfortunately, many of the inpatient detox units have significant waits. It may be a week or two before you can actually get into a bed, and in the meantime, you're withdrawing, and you feel terrible. And there's great motivation and a great pull to continue to use drugs. In our future state, the patient will be given in-person assistance and will be encouraged that long-term recovery indeed is possible and that they can get care right away. Individuals who opt to be discharged to home will be given a follow-up visit in a week by a multidisciplinary team. Those home visits will occur in the company of police. Our crisis intervention team officers are going to be going along with EMS to provide immediate health care if needed, and the peer supporter as a group to try and engage the patient at that time into recovery resources if they so choose. Our go live is planned for fall. We're talking about an October 1st date. That's still kind of in draft format, but that's sort of our plan. And then on a little bit of a happier note, I'm very proud of our emergency department team. We have a fantastic department. We have great patients. We have great physicians, physician assistants. All our staff is really outstanding. And I'm very proud to have the opportunity to lead the group. I'd like to talk a little bit about our operations. We are having very consistent volume and acuity, right where we expected to be. That's where we've been. We have greater than 90th percentile patient satisfaction scores for the year. I'm really proud of our outreach efforts as well with our callback process. We're greater than 97% of discharged patients are called back. So if there are barriers to care, if there's barriers to follow-up, if people can't remember what to do with their prescriptions, who they should see, what kind of issues they're having, sometimes questions come up after the fact that, it's hard to get information from. We give them that opportunity to ask us. We're here for you. We want to make sure that you have excellent health, and this is really a unique program to our team. We're trying to do this across the enterprise, but really the ED at Lakewood is the most compliant with the program. In addition, we have industry-leading door-to-provider times where people really get seen very quickly, and the waits are very minimal. A couple other things very briefly. We have started a telemedicine project with Lakewood EMS where through a secure Skype-like connection, we can provide medical direction not just over the telephone, but also in real time via video linkage. I really truly believe that a picture is worth 1,000 words. And so when the medics have a question about a situation that they're seeing, they can actually connect us directly with the patient, and we can address their concerns right away so that they can give the best care pre-hospital. And again, this is something that really nobody else has locally. And in addition, we are also an educational site and an academic site for our family medicine residents through the Center for Family Medicine, for Ohio University Heritage College of Medicine students. They're third-year students that are going through a required rotation. I have 17 students that will be coming through our emergency department over this school year. We just finished up with our first one, and we also have physician assistant students and trainee physician assistants as well. So I'm very proud of how we've been doing, and we look forward to lots more wonderful outcomes and some unique programs to benefit this city that we love so much. Thank you.
Okay, thank you. I'll go very quickly since I'm the last thing between you and your homes tonight. So I'm here to talk about what we're going to be doing on the ground in the community. This would be things that are done outside of the Family Health Center and the emergency department. Sure. I'm going to introduce the Healthy Communities Initiative. This is a Cleveland Clinic branded initiative that requires community partners, and Lakewood has no shortage of community partners. So the areas that we've decided to focus on as a team are health education, nutrition, physical activity, and lifestyle management. That would include things like stress management and certainly tobacco cessation for this area. Again, we'll be using combined resources that are already here in your community, many of which I think, Martha, you were listing off the people you've interviewed, and I was thinking about all the people that we currently have collaborations with were certainly included in that list. So we'll be developing programming focused mostly on education, awareness, and then strategic programming is kind of what we call the hot topics for the area. So right now, certainly it's the opioid epidemic. In the past, it's been things like Zika, the flu influenza issues that go on based on the area. So again, like Dr. Heckman said, the community health needs assessment is what drives our programs. It's what drives our partnerships and where we're able to put programs on the ground. I'm going the wrong way. So here's just the Healthy Communities Initiative mission statement. It's a collaborative effort between Cleveland Clinic and community partners to promote optimal health and well-being. I know everybody here is a Lakewood resident, so you've probably heard the Live Well Lakewood collaboration that was here several years ago. So the idea here is to kind of resurrect that initiative. We do have Paula Reed, who was kind of leading the charge for that group, on our Community Advisory Council and meet with her regularly. So the Healthy Community Initiative has sort of already been here. We just want to certainly bring it back and use the Lakewood Family Health Center and its staff to really leverage the initiative and make it a lot bigger and better. So we'll be including fitness centers, which of course on every corner in Lakewood there's a yoga studio or a spin studio. We have a lot of gems in the city. Parks, banks, churches, restaurants, certainly, how to eat healthy at Deegan's, I think it's a possibility. Grocery stores, et cetera. So we realize that programming needs to be done, and certainly Cleveland Clinic Lakewood wants to lead the charge on that, but we do realize we can't do it alone, so we'll be looking to our partners to help us out. So some of the goals here, certainly to sustain community partnerships, many of which we do already have. Utilize available resources, which again we've gone through that there's no shortage of that here in Lakewood. Promote economic vitality. So by partnering with Puma Yoga, maybe getting their studio a little more active, certainly finding new members for them. Positively impacts community perception. We are here. We haven't gone anywhere, and we don't plan to. So we are here for Lakewood. And then, of course, increased level of awareness and access to healthy living, because it really is in the neighborhood. And as population health becomes the new wave for Cleveland Clinic, we will be meeting people in the community and keeping them out of our facilities, believe it or not. And then, of course, without outcomes, what do you have? So the HCIs tend to kick off with an 8-week wellness challenge. This is where we get a lot of our outcomes, because we're able to screen participants pre and post on weeks 1 and 8 of that challenge. We'll also continue to assess their health through a risk assessment tool. It kind of puts people into a category of low, medium, or high risk. That way we can track their progress and actually have a measurable outcome as they move through year-long program and ongoing beyond that. So we hope to move them from our high risk into our low risk. So that's kind of the idea right now for Lakewood. We've certainly done this before, and even in Lakewood, you guys have done it without us, so we're happy to be on board and bringing these groups together. We've already met many, many times with people like the YMCA, Lakewood Alive. Lots of the banks and churches have partnered with us on programs already, so we just plan to continue it under the umbrella of a name sort of like Live Well Lakewood, if that's what it ends up being, just so there's some brand awareness there and people know where to come to get healthy options right there in their communities. That's all I had.
Thank you.
Okay, we are going to open the floor for some questions. We'll allot 7 minutes. Janine. And if you could speak in your microphone, please.
Can you hear me? Yes. The purpose of my question is to understand the degree to which low-income people will have access to care at the Family Health Center. So I think this is for you, Dr. Heckman. It was in the news a couple months ago that the Cleveland Clinic has severed ties with CareSource, which ensures a high percentage of Medicaid folks here in Northeast Ohio. And if my understanding is correct, in the past, I know some folks who are covered by Medicaid couldn't always access care at Cleveland Clinic's Family Health Centers. Can you talk about Lakewood's Family Health Centers and how folks who are covered by Medicaid will be able to receive care there?
And could you also include information on the school-based health clinics, which primarily are funded through Medicaid and CHIP?
Sure. So the first two are easy. The third question may be a little bit trickier for me, being in the world of the Cleveland Clinic children's areas and pediatrics focused. But certainly, I appreciate that question. So a couple things about financial support for patients. The Cleveland Clinic has it's called HCAP. I'm not sure what the acronym stands for, but it's our essentially charity care for the population, and that helps folks who make 400% of the poverty level. And so if patients qualify for that, then they certainly are entitled to everything within the Family Health Center, and will be seen as if someone has insurance. If someone is underinsured or doesn't qualify for that, we certainly can work with them. There are certain exceptions that our financial counselors can set up with them. The specifics, we'll have to get more information for you on that, but there are also payment plans that can be arranged. Regarding CareSource, CareSource terminated the contract with us. We didn't terminate it with CareSource. We were actively at the table until the last days trying to get something worked out. Unfortunately, they decided they no longer wanted to have the Cleveland Clinic as within their network. But we want you to know, and we believe this strongly, that we're committed to Medicaid patients. And so we want to make sure that the patients who are on Medicaid have as seamless a transition as they can to the groups that have contracted with us: Paramount, Buckeye, United Health, and Molina, I think, is the other one. We've over the years provided care to 135,000 CareSource patients. Those CareSource patients are now being contacted by over 150 financial counselors to work with them to find out what best meets their particular unique need. We are doing our best to make sure that's an easier transition for something that I'm sure is very stressful for people.
Dan?
Thank you all for being here. I appreciate your...
I didn't answer your question.
What's that?
I just realized
That's
I didn't
okay.
answer your question. But,
that's fine.
But there is a financial counselor available for the school-based health program. The students...
Is that to talk with the kids about their financial situation?
No, they have a registration packet, and they take it home to the parents. The parents review it together, and I believe I'm sure there's a mechanism by which they can call and ask questions about that. The adults, the staff, they will have a same packet, much as anyone who goes to one of our express cares or urgent care setting. They can identify their insurer. And, that's the easy part.
Thank you. And thank you all for taking the time to be here tonight. I know that we're taking you away from your recorded podcasts on population health and from your very healthy meals at Deacon's, so I appreciate your taking the time. My question is more at the 50,000-foot level about your vision for collaboration with the Future Foundation and with the other foundation in this community that is in process. So could you just talk, actually it's sort of a two-part question, I guess. First, your sort of vision for collaboration with the forthcoming foundations, and secondly, to your point about HCAP, in addition to the charity care that you, I would imagine an influx of charity care that your organization will be providing in this community given the severed ties with CareSource. Can you talk a little bit about community benefit and the ways in which, or the programs toward which you'll be distributing funds, or a vision for how you would distribute funds toward population health programs?
Well, to some degree, I think that's what we're trying to work out. I mean, population medicine is something that we are actively pursuing at the clinic. We are finding ways to better care for the patients who come to see us. We know that 2 or 3 visits a year are not the ways. They don't keep people healthy. We need to continue to reach out to patients and provide them with quality care, as well as those who don't come to see us. We need to make sure that we're doing unique ways, reaching them in non-visit related ways. But how we work with the foundation is really a collaborative effort. We need to, so we've shared a bit about the areas where we're involved. We focus on the community needs assessment. We know some of the areas in Lakewood that have the biggest struggles, and we also want to learn more about what the community programs provide, which was why it was so interesting to hear from the Department of Human Services. So all elements of the Department of Human Services, North Coast Health. We want to work with our community partners to find a way to understand how we can fit and complement wellness in this city. It's a group effort. It's not all the Cleveland Clinic that will be improving the wellness of the city. And community benefit, the community benefit is arranged to be 400% of the poverty level, and that's what we'll continue to do. We have financial counselors who will be guiding folks to Medicaid programs. The patient navigator program I brought up is going to be I think a terrific way for us to look at these patients who have barriers to access, be they financial, be they social, be they what have you, to find in that unique circumstance how we best can partner with the community to get these patients in to be seen. If it's with us, great. If it's with someone else, that's great as well. We just want to make sure that they have the care that they need.
Understood. And I don't mean to belabor the point. We can certainly continue this conversation offline. But in terms of community benefit, the charity care is just one fairly small sliver of what's expected to be invested in communities. And so I'm actually I'm asking more about the other large piece of the pie in terms of dollars invested either through in-kind contributions of staff time, or are there multiple ways in which medical institutions invest in communities? So I'm just looking at kind of outside the charity care. Again, not to belabor.
Community benefit is definitely part of Jenny Evans' department. We have community government and community relations. We are involved in sponsorships for events. We've put together the ambulance chase. We've been involved in Lakewood Alive to some degree. We are involved in North Coast Health. There are a number of groups that we have supported over the years, and we expect those relationships will continue.
One of the other things that we do with the community is the Healthy Strides program, and they're having a walk with the doc this Saturday at 10 a.m., and I'm the doc you'll be walking with. Just wanted to put in a plug for my own little program. But there's definitely lots of things that we do with the community, and I think that's something that we continue to work with them as well. The Cleveland Clinic absolutely is committed to taking care of Medicaid patients. In the emergency department, we don't turn anybody away. We see absolutely everyone who comes in, and we treat them the same regardless of their ability to pay. If they would like financial counseling and options for payment, if they need to be signed up for the HCAP program, we do that for them right there on site. We work with them to make sure that their follow-up care is established and that they have places to go to get cared for. If they can't, they come back and see us. And we never ask for a dime, personally. I mean, I'll see anybody, regardless of their ability to pay. And that's our mission, not just as a Cleveland Clinic, but as emergency physicians as well.
I think that may be all the time oh, Cindy, do you have something?
Yes, I do. Thanks so much for coming. Just a quick question. I was wondering if you could explain the Oscar insurance that the clinic is going to be offering. Is that a traditional insurance, do you know, or is it a Medicaid product? I know that it's going to start in January, but I haven't heard any more about it.
From my understanding right now, it's in pilot trials. It's a very limited number of individuals, up to 10,000. And so the clinic is trying to understand what it means to be in the insurance market.
I understand. So is it open to everybody, though? I mean, or is it limited to income qualified, or?
So now
or
my
does
area,
not anybody
now my
know
area
yet?
of expertise. I'm telling you what the things that I've heard about it. Yeah.
Okay, great. Thank you.
Sure.
Councilwoman Marks, we can research that and get back to you.
Okay, our question and answer time is going to be wrapped up. However, if the task force had questions that came up as we progress through this journey we're all on, you would be open to answering those if they came about? Okay, very good. Thank you so much. I know you put a lot of time and effort into preparing this for us tonight, so we really appreciate you taking time away from your patient duties and coming to talk to us and kind of share the population health initiatives that you are going to be moving through the Family Health Center. So it's appreciated. Right, that's how he learned about us, yes. Thank you very much.